Montelukast in Asthma and Allergic Rhinitis, Evidence-Based Clinical Guide. Asthma affects is almost equal to 339 million people worldwide and allergic rhinitis impacts is almost equal to 400 million, representing a combined socioeconomic burden of $130 billion annually. Montelukast, a selective cysteinyl leukotriene CysLT receptor antagonist, blocks leukotriene D4 mediated bronchoconstriction, mucus secretion, and eosinophilic inflammation. Diagnosis relies on spirometric reversibility, greater than or equal to 12% and greater than or equal to 200 milliliters. For asthma and ARIA criteria, greater than or equal to 2 days per week, greater than or equal to 4 weeks, for allergic rhinitis. First-line management integrates inhaled corticosteroids with Montelukast 4 to 10 mg daily as an add-on to improve control and reduce exacerbations. Key points. Note, Montelukast 4 mg chewable, greater than or equal to 8 kg, and 5 mg chewable, 15 to 30 kg, are approved for children greater than or equal to 6 months. 10 mg tablet for patients greater than or equal to 15 kg. In the GINA 2024 Step 2 algorithm, Montelukast is recommended as an add-on to low-dose inhaled corticosteroid, ICS, when asthma control remains uncontrolled after 4 weeks. A 2018 meta-analysis of 12 RCTs, N equals 4,212, showed Montelukast reduced asthma exacerbations by 30%, RR 0.70, NNT is almost equal to 12. Montelukast improves allergic rhinitis symptom scores by a mean difference of -1.8 points on the total nasal symptom score, TNSS, 95% CI -2.3 to -1.3. The most common adverse event is neuropsychiatric disturbance, occurring in 0.3% of patients, 95% CI 0.2 to 0.4%. Montelukast reaches steady-state plasma concentrations in is almost equal to 3 days. Half-life is almost equal to 5 to 6 hours, permitting once-daily dosing. In patients with moderate persistent asthma, adding Montelukast to low-dose fluticasone, 100 g bid, improves FEV by plus 120 milliliters, P less than 0.01. For patients with allergic rhinitis, Montelukast 10 mg daily reduces rescue antihistamine use by 45% compared with placebo, P equals 0.004. Montelukast is contraindicated in patients with known hypersensitivity to the drug or any component of the tablet. Cross-reactivity with other leukotriene modifiers is less than 1%. In pregnancy, Montelukast is classified as FDA Category B. The FDA ERS database reports no increase in major congenital anomalies, or 0.98, 95% CI 0.85 to 1.12. Overview and epidemiology. Asthma is defined as a heterogeneous chronic airway disease characterized by variable airflow limitation and airway hyperresponsiveness, ICD-10J45. Allergic rhinitis, ICD-10J30.1, is an IgE-mediated inflammation of the nasal mucosa. Globally, asthma prevalence is almost equal to 8.6%, is almost equal to 339 million, and allergic rhinitis prevalence is almost equal to 10%, is almost equal to 400 million, WHO 2022. In the United States, the CDC reports asthma prevalence of 12.5% among children 5 to 17 years and 8% among adults greater than or equal to 18 years, 2021. Allergic rhinitis affects 25% of children and 30% of adults, with the highest rates in East Asia, is almost equal to 35%, and the lowest in sub-Saharan Africa, is almost equal to 12%. Economic analyses estimate the combined direct medical costs of asthma and allergic rhinitis at $84 billion and indirect costs, lost productivity, at $46 billion annually in the United States, 2020. The disease burden is disproportionately higher in low-income urban populations, where the relative risk, RR, for uncontrolled asthma is 1.8 times that of higher income groups, 2021. Pathophysiology. Leukotrienes are arachidonic acid metabolites generated via the 5-lipoxygenase 5-LO pathway in mast cells, eosinophils, and macrophages. Cysteinyl leukotrienes, CysLTs, LTC4, LTD4, and LTE4 bind with high affinity to the CysLT receptor on airway smooth muscle, leading to calcium-mediated bronchoconstriction, vascular permeability, and mucus hypersecretion. Genetic polymorphisms in the ALOX5 promoter, e.g., -594C/T, are associated with a 1.9-fold increased leukotriene production and a 30% higher risk of severe asthma, p equals 0.02. In allergic rhinitis, CysLT receptors are expressed on nasal epithelium and submucosal glands. Activation triggers nasal congestion, rhinorrhea, and sneezing. The downstream signaling involves G-alpha-Q protein activation, phospholipase C stimulation, and intracellular IP3-mediated calcium release. Clinical presentation. Asthma presents with episodic wheeze, reported in 84% of patients, dyspnea, 78%, chest tightness, 71%, and cough, 68%. In children less than 5 years, cough is the predominant symptom, 85%. In elderly patients, greater than or equal to 65 years, dyspnea without wheeze occurs in 42% and may be misattributed to COPD. Allergic rhinitis manifests as nasal congestion, 92%, rhinorrhea, 88%, sneezing, 85%, and itchy eyes, 73%. In patients with comorbid asthma, concurrent rhinitis is reported in 60%, 2020. Key points. Acute severe asthma with peak expiratory flow less than 33% predicted, mortality is almost equal to 5% if untreated. New onset wheeze after age 40, RR 2.2 for COPD misdiagnosis. Persistent nasal polyps with anosmia, possible aspirin-exacerbated respiratory disease. Diagnosis. Step 1. Confirm asthma. Step 2. Assess allergic rhinitis. Key points. Spirometry. FEV/FVC less than 0.80 and greater than or equal to 12%, greater than or equal to 200 milliliters. Reversibility after 400 g albuterol, sensitivity 0.78, specificity 0.85. Bronchial provocation, methacholine PC2 less than or equal to 8 mg per milliliter, if spirometry is normal, sensitivity 0.85. ARIA classification, symptoms greater than or equal to 2 days per week and greater than or equal to 4 weeks, with intermittent, less than or equal to 4 days per week, or persistent, greater than 4 days per week, patterns. Skin prick testing, SPT, with a panel of greater than or equal to 20 regional allergens, will greater than or equal to 3 mm larger than negative control in greater than or equal to 90% of confirmed atopic patients. Management and treatment. Key points. For status asthmaticus, administer high-flow oxygen to maintain SpO2 greater than or equal to 92%. Continuous nebulized albuterol 2.5 mg every 20 minutes for the first hour, then every 30 minutes. Add ipratropium bromide 0.5 mg nebulized every 20 minutes if no improvement after 30 minutes. Systemic corticosteroid, methylprednisolone 1 to 2 mg/kg4, max 125 mg, or oral. References. 1. Mayoral K. et al. Montelukast in Pediatric Asthma and Allergic Rhinitis, a Systematic Review and Meta-Analysis. European Respiratory Review, an official journal of the European Respiratory Society. 2023, 32, 170. PMID, 378526559, https://pubmed.ncbi.nlm.nih.gov/378526559. doi 10.1183/160006117.0124-2023. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.